Hello, my name is Vanessa Lopez, and today I'm presenting non-pharmacological birth control methods. What are the most common contraception methods used by women ages 15 to 49 today? Number one is female sterilization, which is non-reversible. Number two is oral contraception, or the pill. Number three is long-acting reversible contraception or intrauterine devices. Number four, male condoms. And number five is all other contraceptive methods. So according to the CDC and to Trussell, Aiken, Mix, and Guthrie, when you're comparing the typical effectiveness of contraceptive methods, they range from Tier 1 to Tier 3. Tier 1, which is at the top of the screen, includes the more effective contraceptive methods, such as what we're going to talk about today, the IUD. And why are they more effective? Because they produce less than one pregnancy per 100 women in 1 year. They also have a high efficacy rate and little wait time after procedure, and there's nothing to remember, no daily pills to remember or other pregnancy prevention measures needed after insertion of an IUD. Tier 2 includes the pharmacological methods. We're not going to go over that today, but Tier 3 includes the non-pharmacological methods we are going to speak about today, and they are less effective because they have more than 13 pregnancies per 100 women in 1 year. So they're considered Tier 3. This includes condoms, sponges, spermicides, diaphragms, cervical caps. Barrier methods. When we think of barrier methods, we need to remember that barriers are created to prevent sperm from entering the cervix to prevent pregnancy. Barriers are also created to prevent sexually transmitted diseases transferring via skin-to-skin contact. These STIs include herpes simplex, chlamydia, gonorrhea. These barrier methods work best when combined with oral contraceptives, intrauterine devices, or other barrier methods to prevent pregnancy and decrease STI risk. Today we're going to be going over non-pharmacological birth control methods, which include the diaphragm, cervical cap, sponge, male or female condom, intrauterine device, and spermicides. The diaphragm. The diaphragm is made out of latex or nylon and metal rim that fits over the cervix to fully cover the cervix. The diaphragm fit can be reevaluated during gynecological visits or multiple times to ensure that the fit is correct and placement is correct at all times for the user. Diaphragm fit changes may have to be made for changes in patient status such as postpartum, post-surgery, and weight gain. Diaphragms require a prescription. They have a 6% failure rate when used alone and a 12% failure rate when combined with spermicidal jelly. It doesn't prevent sexually transmitted infections, so they do really encourage use of spermicidal jelly every time you use a diaphragm. Diaphragm use. Apply spermicidal jelly to the rim of the diaphragm device. Insert device as instructed and do not remove for 6 hours after intercourse. Remove the device and wash with soap and water. Check for holes or tears in the device to ensure diaphragm pregnancy prevention, and it increases the efficacy of the diaphragm. Void before and after device use to avoid UTIs, and do not leave in place for more than 24 hours. These are all education points that the user needs to know to ensure that they are using the diaphragm correctly. Cervical cap. The cervical cap is a rubber cup device that fits around the cervix. A prescription is needed to obtain a cervical cap. The failure rate is between 8% and 23%. Spermicidal jelly should be combined with the device to prevent pregnancy. Cost usually ranges from $0 to $90. Cervical caps advantages. If the patient has a relaxed anterior vaginal wall, the cervical cap would be the best fit. If the patient has frequent UTIs, the cervical cap would be the best fit. This is best to use when the diaphragm is not a great fit for the patient as well. The adverse effects include the same adverse effects as for the diaphragm, which is allergy to the device or risk of cervix exposure if the device is moved during intercourse. Advise patients to remove after 6 to 48 hours after sexual intercourse. Contraindications for cervical cap include pelvic inflammatory disease, pap smear abnormalities, or cervical abnormalities. Vaginal contraceptive sponge. There's no fitting necessary. It fits over the cervix. It is a soft plastic spongy material that contains spermicide and polyurethane. It has a 12 to 24% failure rate and a low cost, $0 to $15. Vaginal contraceptive sponges work when the sponge is saturated with water prior to use, and then it is disposed of after sexual intercourse. It does not provide STI protection unless used with a condom. The adverse effects of the vaginal contraceptive sponge include cervix exposure, discomfort, toxic shock syndrome if left in place longer than 30 hours. Male and female condom. The male condom is a latex or plastic device that covers the penis and prevents skin-to-skin contact during sexual intercourse. It does decrease risk of pregnancy and STIs. Lambskin condoms do not protect from STIs. Over-the-counter condoms are available, and they provide 15 to 18% failure rate. Cost is $0 to $2, Advantages are they can be combined with barrier methods to increase efficacy, as well as STI prevention. Disadvantages include noncompliance, especially with those ages 25 and under. Female condom. It's made from a polyurethane condom that protects the user from STIs by inserting into the vagina or anus prior to sexual intercourse. It also protects from pregnancy. It is available prescription or over the counter. It is disposable after one use, just like the male condom. It has a similar failure rate, 5% to 21%. Low cost, $0 to $3. Advantages, though, are it covers the perineum and cervix during intercourse, decreasing the risk of STIs. And, of course, it decreases the risk of STIs and pregnancy when combined with other barrier methods. Disadvantages include difficult to obtain or they're uncomfortable to place. Spermicide. Spermicide is naloxone 9. It's a component that prevents the sperm from entering the cervix and works in conjunction with other barrier methods to prevent pregnancy. No prescription is needed. It's disposable and 2% to 30% failure rate due to user failure to adhere to instructions, and low cost, $0 to $3. Intrauterine devices. Intrauterine devices are T-shaped devices placed in the uterus to provide long-term pregnancy prevention. They are reversible and can be removed. Copper IUDs are non-pharmacological IUDs that are placed only by a trained clinician. They are non-hormonal and last up to 12 years. The copper component on the IUD prevents sperm from entering the cervix. Pelvic examination is needed to assess before and after placement and for any cervical changes. Contraindications include pregnancy, cervical abnormalities or diseases, cancer, pelvic inflammatory disease. The American College of Obstetricians and Gynecologists agree that adolescents would benefit from IUD placement to prevent pregnancy due to higher efficacy rates, access to healthcare facilities that have trained clinicians to implant the devices, and the long-term benefits of pregnancy prevention, as well as no effect on fertility once removed. The advantages include less than one pregnancy in 100 women per year, which is the Tier 1 contraceptive method. No other forms of birth control is needed to prevent pregnancy. It's easy for users to check IUD placement by checking a string. Disadvantages include pain with placement, heavier or irregular menses, does not offer STI protection. And once again, pelvic examination is needed to assess prior and after placement and for any changes such as postpartum, such as chances of pregnancy, as well as to check for placement in case the user has any difficulties finding the device string. Contraindications include pregnancy, cervical abnormality or diseases, cancers, and pelvic inflammatory disease. And to note one more time, this is the effectiveness of contraceptive methods in general based on efficacy.